Good afternoon, everyone, and thank you very much for joining us today. In 1846, the very first public demonstration of ether anesthesia occurred here at MGH, and it went on to revolutionize medicine and surgery at large. More recently, we at Mass General have been going through a renaissance of some sorts in understanding brain health during the period around surgery. I think what's clear to us is that our scientists and our doctors are beginning to clearly define how the surgical period challenges our brain health. We're learning a lot more about cognition, about mood disorders, and sleep right around surgery. I think what we're starting to learn is that this challenge around our brain health gets a little bit more challenging and tasking when we age and as we age normally and gracefully. Today, you're going to hear from two of my very, very close colleagues, Dr. Hiroko Kunitake, a GI and colorectal surgeon at MGH, and Dr. Patrick Purdon, a neuroscientist and bioengineer at MGH. They're doing some pretty cool and important work that is helping us understand how to better maintain our brain health during surgery and after surgery. And I'm really excited to hear a little bit about what they've been working on, and I hope you'll join me in welcoming them to talk about some of their pretty important research. And with that, I will turn it over to Dr. Kunitake and Dr. Purdon.
Thank you so much. Maybe I'll just kick this off. Patrick and I have been working together over the past couple of years about how we can really improve cognitive outcomes for our surgical patients. And we're really excited to show you some of the progress that we've made and what we envision for the future of patient care. Patrick will kick it off here.
Sounds good. Hiroko, do you want to screen share?
Yes.
All right. So actually, let me start off by telling you that in addition to, initially discovering anesthesia in 1846, we actually think in today's modern times that we here at Mass General have actually finally figured out the 170 plus year mystery of how anesthetics actually work. And how they work is that they engage the brain in these rhythms that sort of disrupt normal brain activity. And one of the key brain areas that anesthetic drugs act is this area of the brain called the prefrontal cortex. And you can see that on the upper right section of the screen here. These kind of brightly colored areas are among the areas that anesthetic drugs sort of work to, if you will, disrupt transiently brain function. It turns out that these areas of the brains are in this prefrontal cortex is the same, set of brain areas that show neurodegeneration during aging and neurodegenerative diseases such as Alzheimer's disease. And you can see how that plays out under anesthesia in the bottom screen. These lines are indicative of the anesthesia-induced brain activity that occurs as a function of a person's age. So age in years is on the x-axis here. And you can see that as we get, right, thanks, Hiroko. As we get older, one of those brain waves, the upper one, seems to get more and more faint. And that brain wave is exactly the one that is depicted in those, is coming from those exactly from those areas that are depicted at the top of the screen. So it's not surprising that as we age, our brains are reacting differently to the anesthetic, and maybe our brains actually need less anesthetic or different anesthetics as we get older. Hiroko, let's go to the next slide. Yeah, and you can see that in this panel as well. On the upper row, you see that as we go from middle age to progressively older patients, that little kind of upper line at around 10 cycles per second is getting fainter and fainter. And what we've learned over the past several years is that as patients age and maybe have sort of different brain aging that's very individualized to them. So on the bottom row, we see two different 50-something year olds. One on the left-hand side that looks more like a younger person, and one on the right-hand side that looks more like an older person. And what we've learned is that the person who looks has an older-looking brain, irrespective of their chronological age, more than likely has a lower cognitive ability and actually has lower anesthetic requirements, and finally a lower sort of resiliency, if you will, to anesthesia and surgery. And those patients are more likely to have poor postoperative cognitive outcomes. And it turns out, though, that if we were to alter slightly the care of those patients, say by monitoring their brains under anesthesia, trying to reduce their anesthetic exposure, we could significantly improve their cognitive outcomes. And then in addition, if we were to actually place those patients into special programs where we actually are following them more closely through the course of their intraoperative and postoperative care, we could also significantly improve their outcomes. And that's our goal here. We're going to do exactly that.
So Patrick and I started talking about this idea of how we improve the future cognitive health of our patients undergoing surgery and anesthesia. And actually, over the past couple of years, our group of discussants and sort of participants in this project has really expanded. And so just as a recap, today's patient experience, somebody who's undergoing surgery gets their diagnosis, of course. They may be a patient at risk, but we don't really necessarily look at all of those risk factors. They kind of go through a process where they're evaluated for the surgery, looking very specifically at the one problem that they may be having surgery for. They go to our surgery clinic, they undergo surgery with anesthesia, of course. They have an inpatient stay and they're discharged. So a very straightforward pathway. What we envision, however, is something a little bit more complex, a little bit more individualized, actually. So somebody may have a diagnosis that needs a surgery, but actually there are multiple other factors in play here. They may have issues with other comorbidities, some cognitive disorders potentially. They may be frail. They may have some impaired functional status, maybe some anxiety, depression, other hearing or visual impairments. They may actually even have some medication issues that we need to deal with. So all of those factors on this patient are evaluated prior to surgery. Then we actually have a more full discussion on what does the patient want? What does the family member want? What does the caregiver and family feel like, along with the patient, is their ultimate goal with this surgery? And that's really what matters most to them, whether it's mobility, whether it's cognition, whether it's something about their medications, multi-complexities. We want to come up with a personalized plan. And that personalized plan can involve prehabilitation potentially to try to strengthen them and prepare them for surgery. Certainly cognitive outcomes, cognitive function is dependent on nutrition, physical care, the anesthesia, the post-op care plan. So all of these things are going to be individualized to each patient. And then during surgery, Patrick's team and others are going to be monitoring their brain and actually individualizing the anesthesia that this patient is receiving. Finally, after surgery, of course, we talk about continuity of care and how we're going to manage their recovery at home and then potentially in the hospital and at home. So this next slide shows what we hope will be a better continuity of care that is personalized, that's seamless, that starts in the hospital to try to improve cognition, physical function, nutritional function, engaging the patient and their caregivers along the way, and then continuing at home where we can optimize these sorts of things over time, because we know that recovery doesn't happen in a week. It doesn't happen at discharge. It happens really over a long period of time. And we're talking about ongoing patient evaluation. So this is our hope in terms of patients who are in the hospital having surgery, but ultimately cognitive recovery, cognitive function is actually something that goes way beyond just the surgery, beyond in-hospital care. And it's something that we hope can progress over the entire stay of a patient at MGH, whether it's from the beginning when they register as a patient to when they actually leave the MGH system. So our main two outcomes in this project really have come out to be cognition. How do we recover cognition long-term? And what kind of factors are actually involved in preserving and maybe even improving cognition, whether that's in the immediate post-operative period, whether that's nutritional, functional independence, et cetera. And then secondly, and equally importantly, engaging the patient in their care. How do we get patients to feel that they're involved in making the decisions? How do we make sure that we're actually aligned with their main goals? And this is expanding communication with the patients and their families, and then aligning our treatment, of course, with their personal goals. So we have some, maybe I'll stop here for a moment and ask Patrick and Dr. Akeju Johnson if they would like to add anything before we move on to our further slides.
Please move on.
Okay, we'll continue. So, of course, this is a complicated endeavor. I think one of the things that Patrick and I have really enjoyed as we think about this problem, as we try to plan how we're going to accomplish all of this, is basically that it involves multiple areas in the hospital, whether that's nursing, whether that's patient navigators, of course, the physicians that are actually taking care of the patients during their hospital stay. But long term, this requires infrastructure, things that we can establish at this hospital to really track cognitive outcomes. I mean, it would be wonderful if, as soon as a patient registers and gets a medical record number at MGH, we use cognition as one of the vital signs, and we measure this over time, so we can actually follow a patient over time. Just like we know somebody gets high blood pressure or becomes diabetic, we can say over their visits to their primary care physician, for example, that their cognition is changing and we need to actually intervene so we can give them the best possible outcomes. So these are things that need a lot of infrastructure. So listed here are some of the things that are required for us to be able to do this, whether it's establishing personalized care plans, building these integrated and collaborative care teams to monitor cognition, monitor all of these things that we want to improve, whether it's collecting and analyzing data. This, of course, requires data analysts, people that are integrated into our medical record system. And ultimately, what we hope is we will actually change the way that patients are cared for, that the priority will become improving patient outcomes, not just treating the disease. And what we hope is that this will attract the next generation of healthcare leaders that are focused on these outcomes. And we envision potentially having fellowships in this area, attracting the greatest and brightest minds in the country to come and work here and help us continue this endeavor. Last slide for today's webinar is just about required resources. So, of course, as I mentioned, this takes a village, and it requires team members all the way from the patient registration system and how we sort of monitor and collect this data, all the way to the patients, of course, that are the treatment members and the care teams that are happening that we are going to put together for our patients. So researchers, program partners, program leaders, these are all things that we are working on enrolling, putting together for our patients. So finally, I leave it open, I think, to any questions. We have a few minutes for questions here, and I leave it at that.
Thank you very much, Dr. Kunitake and Purdon, for that wonderful talk. So we have a few questions here. The first question really borders on, we understand what we could do during surgery, we understand what we could do after surgery, but is there anything we need to be thinking of before surgery to make sure that we're able to take care of our cognitive health after surgery?
Yeah, maybe I'll start off. Yeah, I think one very simple thing that we could do, that we're planning to implement in these new pathways that we're envisioning, is simply to measure cognition ahead of time. I think if we know ahead of time that someone maybe has pre-existing cognitive impairments, we can understand that their risk for longer term cognitive issues is elevated, and we can kind of take the necessary steps to prevent that from happening. So I think that would be one thing immediately that we could do.
Another, that hot topic sort of out there is prehab. I mean, prehab in many centers means nutritional supplementation, or maybe some exercises that are done for the few weeks before somebody undergoes surgery. But actually, prehab can be extremely broad. I mean, this can be also some sort of cognitive testing, cognitive sort of exercise in a way, if we can call it that. And I think that since all of these components, we know nutrition, physical function, there's social situations, all of these things really impact cognition. We're looking at something that potentially, yes, we can enhance ahead of time. And then, as Patrick was mentioning, monitoring cognition pre-surgery, which is actually happening in some of the very exciting research projects that are ongoing at the moment, monitoring cognition after surgery and sort of understanding what the trajectories are and how we can get the best outcomes for our patients. These are all things that are ongoing at the moment.
Thank you both for that answer. We have a few more questions in the chat. I think one of the questions we have is, what makes MGH special? And are there any other centers out there that are trying to do similar brain health monitoring right around surgery?
Yeah, maybe I'll start off that one. So there are definitely, I mean, this is very cutting edge, actually. I mean, so there aren't a ton of centers out there, but there are a few that are working on something similar. And actually, we've learned a lot from them. I mean, for instance, at one of the centers, the mere fact of having an integrated care team that involves, say, geriatricians evaluating a patient's health at the beginning before surgery, that leads to better outcomes, irrespective of anything that happens downstream. I think here at Mass General, we can certainly do that, but we can really kind of elevate the approach in a more sophisticated way to use measurements, whether pre-op cognitive assessments, brain monitoring, post-op assessments that are more sophisticated, but also build in quantitative models that can actually track and sort of improve care continuously throughout the system and for an individual patient. So sort of the quantitative aspect is something I think we're going to end up doing much better. And then I think the fact that we're teaming up as two departments, surgery and anesthesia, and other departments in the hospital as well, to really create a continuous pathway, I think that will actually improve care well beyond what some of the other sites have begun to do.
I might add something, which is just that, for a long time, I think surgeons looked at a successful outcome as somebody who did not get readmitted, did not end up having a wound infection, those kinds of things. But I think what this has shown us is that actually the outcomes that patients care about are far different than what the surgeons traditionally have cared about. And, length of stay or those kinds of things are not really on their forefront. It's getting back to living at home and living independently. It's getting back to being able to do the things that they wanted to do. It's being, back to their baseline cognition. These things we know take a lot of time, particularly for older and frailer patients. And when I say a lot of time, I'm talking about sometimes months, sometimes a year kind of is the correct measure. But I think what is so exciting about this project, this endeavor, this joint project, is that we really hope to change what surgery, what successful outcomes from medical care is. We're really pushing the envelope here to make it patient-centered, to make it what the patient really wants to achieve. And I also would say just that, another thing that really is wonderful, as kind of we've all talked about, is that surgery is a very strong department here at Mass General, but so is anesthesia, is basically born here. And I think what is really fascinating is that the best researchers, the best maybe clinicians, if I can say that, in the country, are able to participate in this type of a collaborative project. And that just is very, very exciting. I think that we have really, really a lot of potential for wonderful things for their patients.
Thank you, Hiroko and Patrick. We have a few more questions in the chat. So the third question is really trying to get a perspective on what particular resources this program will provide to patients or the system in the postoperative care. If you could just, I know you talked a little bit about this, but if you could just, give us a little bit more detail, we'll appreciate that.
Maybe I'll just start off on this one, just because one of the things that's actually already ongoing is a clinic where we evaluate frail patients. And sometimes, when patients are coming with their family to talk about surgery, let's say to our surgery clinic, and we give them the options of, surgery, or sometimes no surgery is actually the better option. And I think what's really wonderful is we have a multidisciplinary clinic to optimize patients and sort of evaluate them prior to surgery. It's run by actually our geriatricians in collaboration with physical therapy, social work, nutrition, anesthesia, surgery, of course. And these patients are evaluated in a much deeper level, usually with their caregiver. And the true frank discussion comes really about, what makes the most sense. Surgery is not necessarily the answer all the time, and so I think what's wonderful about this particular clinic, and this is just one example, really, of what we offer, but the one thing that's really wonderful is it allows us sort of the opportunity to step back and really assess what's important, what matters most, again, to the patient and their caregivers. So that's just one thing I would say. And Patrick, maybe you can add along some of the other things.
In terms of the resources to assist patients post-operative care, I mean, one of the other things that we're actually actively constructing right now is a special pathway for older patients. So there are these what are called enhanced recovery after surgery pathways that are intended to improve recovery after surgery, but they're really not optimized for older patients. So we're working on one that would really be tailored to older patients, and would say take information about their state of cognitive health or frailty preoperatively and be able to sort of fine tune their pathway, inclusive of the postoperative care regimens. So that's definitely something we're doing, and and overall, I would say that everything we want to do in this program is really cutting edge, but also really tractable. It's something we can really, really do if we can get the resources to kind of build this infrastructure.
Actually, and I'm sorry to add even more to that, but I totally agree that, these pathways and sort of the infrastructure in how we identify these patients, how we can intervene quickly because we can identify them electronically, say through the medical record, is critical. And so one of the biggest pushes I think that we're working on, and we would need more basically support for, is coming up with ways that we can build this into our medical record system. Because I think that in order to really scale this up and to be able to affect every single patient that comes through Mass General, I mean, of course, we're talking about thousands and thousands of patients, then we need a way that we can do this in an automated form. So I think that's probably one of the biggest resource things that we are working on and need. And then the second thing I would say is sort of what can we offer to patients? I think the wonderful thing about Mass General is that it's very multidisciplinary. So, not only are there very strong endocrinologists or, the kind of the cutting edge in cardiology and, anesthesia, of course, and those kinds of things, we're able to, as a team, really offer the best care, the most tailored care that a patient might need. So what I always personally tell patients is when they're thinking about having surgery here is that, sure, the anesthesia and surgery is good here, but really what it is that if you have anything else that comes up that's unexpected that we need to deal with, we have everybody that we might need readily available to help with that. And that's really wonderful. That's very unique here, I feel.
Yes. Thank you. Thank you again, Hiroko and Patrick, for that answer. The last question I have really borders on trying to understand what causes the issue after surgery in terms of brain health. Is this an anesthesia issue? Is it a surgery issue? Or is it something that your new program is going to help us get to the bottom of?
I think the answer is probably all of the above. Is it a surgery issue? I think certainly yes. We know that during recovery from surgery, there's a tremendous inflammation that the body undergoes as part of the healing process, and that inflammation can actually, in a way, cause brain dysfunction. We know that. And is it an anesthesia problem? Yes, in part. We know that, say, out of 100 older patients, approximately 25 might have this serious neurocognitive disorder called delirium in the postoperative period. We know that if we were to monitor people's brains during anesthesia and actually try to minimize the anesthetic exposure, we might prevent delirium in about a third of those 25, percent of patients who experience delirium. And then, will our program kind of get to the bottom of it? I think absolutely, because as Hiroko mentioned, a huge part of this is to have this informational infrastructure where we're actually learning everything we can about the patient beforehand, learning everything about what's happening to them during surgery. We can certainly get to the bottom of the different sort of factors that sort of influence the cognitive outcomes. And then I think because we are building this kind of continuous pathway, we also have the opportunity in the future, if we come up with new interventions at any point in this sort of continuum of care, we can actually kind of plug them into our system and actually be able to test out in a very rigorous way, what does and doesn't actually improve outcomes.
I don't think I could say it any better than that.
Thank you both. So sadly, we're at time, but I just want to thank you both, Drs. Kunitake and Purdon, for taking time out of your busy days to really give us a sense of some of the exciting work that's being done at Mass General. I also want to thank all our viewers for logging in and really listening to some of this exciting work. If you want to support this work and other work, please contact the MGH Development Office. We look forward to hearing from you and also sharing some of the updates from this work in the near future. So thank you all for joining us, and have a great rest of your evening.
Thank you.
Thank you.